This is Outbreak News This Week, brought to you by The Global Dispatch Incorporated on Talk Radio 860 WGUL. Outbreak News This Week is your source for all the news about worms and germs. And now, your host, microbiologist and editor of OutbreakNewsToday.com. Here's Robert Herriman.
Good afternoon and welcome to the show. My name is Robert Herriman, and it feels great to be back on the air after a short hiatus, and I pray that this relationship with WGUL turns out to be a long one. Let me first go ahead and introduce you to myself and the program. I am a microbiologist by training of more than 25 years. In addition, I am the editor of the news site OutbreakNewsToday.com. I encourage you to visit the site. It's categorized mainly by geography, continents, and countries, making it really easy to navigate. And I hope you become someone that will bookmark the site and to get the latest up-to-date news. This radio show, Outbreak News This Week, is dedicated to infectious diseases. Outbreaks here, right in our own backyard, and those abroad. And I'm also going to include important research that's being done in these various fields. Before I have my first guest on, I want to talk a little bit about Ebola in the U.S. and try to put things into perspective a little bit. We've had 9 people treated for Ebola virus disease in the United States. And out of that, we've had, unfortunately, 1 fatality. 7 people have been treated and released. And we still have 1 person that's still hospitalized with their disease. And I think a big point to make here is there's only been 2 secondary cases, and both of them are the 2 nurses from Texas Health Presbyterian Hospital in Dallas. And clearly, they were in a lot more danger. They were treating a patient that was dying from Ebola, and they're in the latest stages when Mr. Thomas Eric Duncan was, his viral load was massive. He was spewing out fluids by the gallons, and of course he was the most infectious. And you have these poor nurses that were caught off guard. They weren't properly trained to use personal protective equipment, and it was just the perfect storm for infections. But put that into perspective: 2 secondary cases. I've heard, some radio talk show hosts on and people on cable news talking, spewing such hyperbole like, hey, I need to wear a hazmat suit to go bowling, in reference, of course, to Dr. Spencer in New York City. And I want to emphasize to everybody out there that there has been no Ebola transmission in the public. 0. So it's not that transmissible. You're not going to catch it from picking up a bowling ball. So, and let me talk a little bit briefly before my guest calls in about the 1 fatality we did have, which was the Liberian man, Mr. Duncan. Now, I give the Dallas hospital a break, because if you put up a map of the United States, it's like playing pin the tail on the donkey. Of the 4,000 to 5,000 different hospitals, they were just the unlucky one to receive the first case, and they were clearly unprepared. There's no doubt about it. Mr. Duncan was sent away. He didn't start treatment right away, and of course, I believe the CDC was caught on their heels too. But I believe now we have everything together, and the concern should be, next to nil. Mr. Duncan, of course, was sent away. He was misdiagnosed initially with a sinus infection, and he wasn't able to receive fluids and all that early on. He wasn't able to receive any of the Ebola antibody-rich plasma from other survivors because of his blood type, according to reports. So he had a lot of things going against him. But the fact that, right now, 8 out of 9 have survived to date says quite a bit about Ebola in the United States. So let's not panic too much. Now let's take a look at where the real crisis lies, the real catastrophe, and that's in West Africa. Joining me on the phone to look at this crisis, the Ebola outbreak in West Africa, and to see how we got there and where we headed, is Tara Smith, PhD. Dr. Smith is an associate professor with the Department of Biostatistics, Environmental Health Sciences, and Epidemiology at Kent State University's College of Public Health. Hi, Tara, and thanks for joining me today.
Hi, thanks for having me.
Let's go ahead and start with this, Tara. There's been a couple dozen Ebola outbreaks since 1976, and in several outbreaks of Marburg virus, a cousin of Ebola with very similar transmission and disease. But the outbreaks never exceeded 425 cases in total. That was the worst ever, as far as cases. So my question to you is, why did this outbreak get so bad compared to the other previous 24, and what factors are different about this one?
So there was a couple things that contributed to this outbreak getting so enormous. One is that it wasn't recognized for almost 4 months. So it started in December of 2013, but international authorities really weren't on the scene until March of 2014, and even then in kind of a limited capacity. So by that point, it had already spread from Guinea, where it initially began, into Sierra Leone and Liberia. And the place where it started in Guinea was right kind of on the border of all of those countries. So it had already crossed borders by the time it really got international attention. After that, then, that became an issue that you're trying to track this not just in one area, but in 3 separate countries where people can move pretty fluidly across all of these international borders. It was also an area that is much more urbanized than we'd seen in previous outbreaks. Most of the previous outbreaks tended to be in more rural areas. It spread very occasionally to some of the larger cities, but mostly those were isolated cases, and there was never anything that ended up in a big outbreak in those cities. So those were 2 of the issues. 3 is that we'd never seen an outbreak in West Africa before. There had been 1 case of Ebola in the Ivory Coast, but that was an isolated case. It never led to an outbreak. So this was a place that had never, had no experience with Ebola. And then, of course, these are countries that are among the poorest in the world, that have really poor health infrastructure. In Sierra Leone, they only had about 50 doctors, period, in the whole country. So it's just an area that is completely underserved as far as health care. They've undergone civil wars for, the last decade. So a lot of the infrastructure in general was just gone. So you had kind of a perfect storm of really political, social, urban, economic issues that contributed to making this outbreak really huge.
Right. Now, I want to point out that Dr. Smith is also a recognized expert in zoonotic infections. And that leads to my next question that, we talked about patient 0, the Guinea child who contracted the virus in December. So for any of these Ebola outbreaks or the Marburg outbreaks, the initial case, how does that individual contract the Ebola virus?
Usually it's from some kind of exposure to wildlife. In this case, it does appear to be probably exposure either to a bat or to bat droppings. The family that had the initial case did note that they hunted bats, and bats are eaten in Guinea. In other outbreaks before this, in some cases, it's been people who have worked in factories, like cotton factories, that are infested with bats in the rafters, so potentially exposure to bats there. In some cases, it's been people who have traveled to particular caves that are heavily infested with bats, and they've come down with Marburg virus from visiting those caves. In some cases, it's hunting animals that may have gotten an infection from bats. So, of course, bats aren't the only ones that live in the forest. There are all kinds of primate and non-primate species. And so in a few cases, it looks like the index case, the person who was first found to be infected, had either butchered or eaten animals from the forest that may have been infected with Ebola and ended up with it that way. So in all cases, it's what we call a spillover, a transmission from some kind of wildlife into the human population.
Okay, great. Now, earlier this week, or late last week, the head of the International Red Cross said that with good isolation and treatment for those who were confirmed cases of Ebola, along with proper burials for those who died, this outbreak could be over in about 6 months. And of course, this is a big if, because as we saw, very recently, an Ebola-affected child found her way into Mali, making that country the 6th one to confirm the virus. And on Tuesday, the latest MMWR report kind of said that the outbreak is spreading to more and distant counties in the 3 most affected countries. So I guess my question is, what are your thoughts on this? Is the head of the International Red Cross on target? Do you see the progress headed that way, or is this going to be a long, drawn-out thing?
Yeah, and it's still so hard to tell. I hope they're right. I think every international, every person following this outbreak hopes that they're right, that this would be over in 4 to 6 months.
Right.
And projections just vary so widely from this going on, for a year or more to this really never coming to an end and kind of becoming just an endemic infection that you're always going to have to be fighting. I really don't know. There has been some potentially positive news just out today or yesterday that in Liberia, it looks like the rate of new infections may be slowing down.
Yeah, I saw that.
Yeah, so whether that's real, they certainly were concerned about maybe it's slowing down this week, but next week will they see a spike, whether this will be a sustained trend of a decrease in new cases or not. So I don't know. I'd like to be optimistic, but I just think it's too early right now to say one way or the other, really how long this is going to go on.
Yeah, and as a matter of fact, the WHO just came out about an hour ago saying the case count is now, pushing 14,000. So, yeah. And then secondly, one thing that a lot of people in the United States hear about are these bizarre burial practices in Africa. And of course, this is a main contributor to Ebola outbreaks. There's no question about that. Can you kind of explain what these burial practices are, and do you see this improving?
From the sounds of things, it has. Again, looking at the Liberia story, that people seem to be cutting back on some of the ritual burial practices. So it of course, varies a little bit from place to place. But in many places, family members will conduct kind of a ritual washing of the body, especially female family members, to clean the body off and prepare it for the afterlife. In some cases, they also do a lot of touching and, in some cases, kissing of the body, which is really problematic for Ebola because people are most infectious really very late in the disease. That's when they have the highest viral loads, and that's when they're most capable of spreading it. And even after death, the bodies still remain very infectious. So that's why you see people working, putting corpses in double body bags and being very careful with these dead bodies. So that, unfortunately, has contributed to the spread of Ebola because they are so infectious even after death. It sounds like they have done a lot of education campaigns and tried to work with people to really get them to cut back on these practices. And it sounds like it's making some headway in that.
That's good to know. I am talking to Dr. Tara Smith with Kent State University, and we are talking Ebola in West Africa. All right, so in the past week or so, we saw Nigeria, Senegal, both being called Ebola-free. They met the World Health Organization criteria of 42 days without a new case. And also, we're seeing that the Democratic Republic of Congo, which has a totally separate Ebola outbreak that probably a lot of people don't even know about because there's no publicity about it. They're on the clock right now. So that's getting close. So a lot of people are using Nigeria as the example. This is how you're supposed to do it. And some people may have a point because the case that came from Liberia landed in Lagos, which is one of the most populous cities on the planet. So this could have been a disaster. My question for you, Dr. Smith, is what did Nigeria do so well?
Yeah, they did, really basic shoe leather epidemiology. They did home visits for people. They went out on literally thousands and thousands of visits to people who were contacts and contacts of contacts to check their temperature, to check for symptoms, to make sure that they were taking care of themselves and paying attention to, their keeping in their homes and things like that. So it was really a very impressive work of epidemiology and of public health and of sheer manpower to get this done. So they had great success. They did not have any other cases after kind of the first outbreak in Lagos, and then kind of the second outbreak that stemmed from that in Port Harcourt. But yeah, they did an amazing job of keeping those contained once they realized kind of what was going on and had the Ebola diagnosis.
Okay, let me switch gears a little bit. And what we're seeing now is a massive push for several vaccine manufacturers, the drug ZMapp, which caught a lot of publicity in the news. Mm-hmm. And I guess my question for you would be, is this an answer for putting an end to the outbreak or preventing future outbreaks? Or how is this going to fit into the whole picture? Mm-hmm.
Well, I think there are other tools that we can have in our arsenal. Vaccines, obviously, if we could get especially healthcare workers vaccinated, because they're, of course, at the front lines, and they're the ones that are treating large numbers of these really ill patients, and they're the ones who have gotten sick in large numbers and died from contact with these patients. So I don't think there's going to be any kind of big, mass vaccination campaign where they're going to go out and try to vaccinate, 12 million people in the 3 affected countries.
Right. It's not going to be like polio or something.
Right, exactly. And you don't need it for that. You need to vaccinate the people that are in close contact with these people, maybe in some of the affected counties. But I just don't know. If the Red Cross is correct and this outbreak is over in 6 months, that's probably going to be before we get actually any of the vaccine, ready for prime time. So hopefully, I think this outbreak may burn out before we get that ready. For ZMapp, it's a little different. One, that takes so long to manufacture, and two, we don't really know how effective that is. They've obviously given it on trial basis to some of the people who ended up getting Ebola infections, including Kent Brantley and Yancy Wright-Ball. I forget how all of them, they had to split a dose or something. Right. Mm-hmm. But in that case, obviously both of them survived, but some people who had gotten ZMapp did not. And it's hard to know if it was the ZMapp that gave them an edge and allowed them to survive the virus, or if it was just, having care in the United States, like we've seen with other people that, as you mentioned, most of them that have come here have survived. So that one, I think, is a little more of a question mark.
And I just wanted to ask you something about what's happening here in the U.S. We see Kent Brantley and, of course, Mrs. Wright-Ball donating their plasma. There's this Ebola antibody-rich plasma, and that certainly appears to be helping, because some of these nurses, I don't think they've been staying in for the whole 21 days.
No, they've been declared virus-free and let go.
Can we give credit to that?
Yeah. And again, we don't know.
Yeah, I suppose. Yeah. And N equals 2. I get it.
Yeah, exactly. We don't have a good clinical trial, randomized, done in the same hospital, or at least in the same, country or something, right. Where we've given a large number of people the plasma, whether it's from the same person or not, but plasma that contains antibodies versus people that have not gotten that and looked at survival rates. And, we have not been able to do that. So whether that's helping or not, we still, don't know that either.
Okay. And, of course, we are talking about Africa. So Ebola is not the only infectious disease there. Mm-hmm. So you got all these hospital beds. They can't even come close to handling the Ebola load. And so what's happening to all these patients with malaria and the millions with diarrheal disease and tuberculosis? What are the short and or long-term effects that you see from this?
Yeah, short-term effects is that it's going to be an increase in mortality from these other infectious diseases, and they've seen that already. Again, it's hard to get great numbers in these countries because so much is focused on Ebola right now. But just from kind of anecdotal reports of others in the country and on the ground there, I mean, there are no places to treat these other diseases. There are no places even for, women to go and give birth in hospitals and things. So probably there will, you'll probably see a spike just in general neonatal mortality of pregnant women and women who've just given birth. I mean, in some cases there's food shortages. I mean, you have so much else that's going on besides Ebola.
Well, exactly. And that's, I'm not even talking about the economic situation that's going to, what a mess. Let me ask you a question a little bit closer to home. Past couple days, there's been a lot of back and forth about quarantines. As a public health professional, as an infectious disease expert, what are your thoughts on the quarantine issue?
That quarantine for Ebola does not seem to be recommended. We have no indication that people are able to spread the virus before they show symptoms, and even then, again, it appears to be rather late in the disease. I mean, look at, again, Thomas Eric Duncan's family. He was around them for several days, before he reported to the hospital the first time, sent him home. He was ill around them for several more days. None of them got sick. They're all out of that 21-day incubation period, and no one came down with illness. The only people that were infected from him were the nurses that were caring with him at the end of his life.
Exactly.
I think for quarantine, for this type of situation, it is not recommended. I mean, Doctors Without Borders have long had a policy of self-monitoring and reporting to healthcare authorities if you do show any symptoms, which is exactly what Dr. Spencer in New York did. So I think that's as good as anything. I don't think adding quarantine and adding this additional level of both legal issues and, really just inconvenience and hardship on these people who have gone over to treat Ebola in Africa is going to do anything but, appease the public and appeal to, political situations.
Yeah, and something I mentioned in the intro, the cable news networks and the talk radio people, I mean, they're saying, I got to wear hazmat suits to go bowling. And I mean, the hyperbole, it's funny because last week I was telling my business partner, I said, man, if I didn't know anything about Ebola, I'd be scared to death right now. And sure enough, the next day I was talking to my mother, and the first thing she said to me was, what do you think about this Ebola thing? It's so scary. And Ma, it's not that scary.
Right.
Unless you're in Africa.
Right, yeah. Exactly. In the United States, I mean, there are so many other things to worry about as we go about our daily lives. I mean, getting hit by a car, getting influenza, slipping in your bathtub. You're going to be more likely to die than to die of Ebola. But it is hard because the news media is largely hyping the threat. And we were just talking to some people. Obviously, we had our own Ebola scare here at Kent State. Right. And we were talking about the news media, some of the local stations from Akron and Cleveland their coverage was exaggerated, shall we say, versus actually our student newspaper here at Kent State, which did fabulous. They interviewed, myself and some others who have knowledge of Ebola here, and really said, you don't have much to worry about. We're not worried. We should come together as a campus, and they had great coverage. Great. So, but of course, they're not really working for ratings and things. So I guess fear sells, as the news media has definitely shown. Yeah,
that's unfortunate. Okay, I've been talking to Dr. Tara Smith. She's a Kent State University professor of biostats and environmental health and epidemiology, infectious diseases, and the whole gamut. And I appreciate you coming on the show, Tara, and thanks for your expertise.
Absolutely. Thanks for having me.
All right. Have a great night.
Thanks. You too.
Okay. So that pretty much winds down the first half of the show. I, again, want to encourage you to visit the website. It's outbreaknewstoday.com. You'll catch all the latest and greatest news, up-to-date news, not only on Ebola, but there's a whole bunch of other things going on right now, too. I mean, we have West Nile, we have chikungunya, there's dengue fever, and there's just a lot of stuff going on right now. So I encourage you to check it out. And again, that's outbreaknewstoday.com. We'll be right back.
Outbreak News This Week with Robert Herriman continues after this.
With SRN News, I'm Wally Hines in Washington. Safety is the reason police gave when they asked the U.S. government to restrict airspace surrounding Ferguson, Missouri for 12 days back in August. But audio recordings now show that local authorities privately acknowledged the purpose was to keep away news helicopters during violent street protests. Pierce Manufacturing's recalling 135 fire trucks in the U.S. because of a suspension problem that could cause a wheel to fall off. It happened to 2 trucks responding to emergencies in Oregon and Oklahoma. Nick Walunda takes his high wire act to Chicago tonight. Walunda plans to walk uphill from the West Marina City Tower to the top of a skyscraper on the other side of the Chicago River. Then he'll walk between the 2 Marina City Towers wearing a blindfold. He'll do it all without a safety net or a harness. More details at srnnews.com.
Intelligent Talk with Dennis Prager.
Why does change excite the left? Because it gives them meaning. There is more to do. Everybody believes that there is more to do in improving the world, but they're transforming the world. That's what the left stands for. So Obamacare is just one part of a long journey.
860WGUL.com.
This is Uncommon Moments. Here's former Super Bowl winning NFL coach Tony Dungy and his wife Lauren sharing from their book Uncommon Marriage.
When you help others, you're actually helping yourself. As coach of the Indianapolis Colts, I got to know my players well. We became like a family. I heard about their personal family problems. Being a coach was more than winning. It was also about caring for others.
I can remember Tony telling me about his players. We thought it a privilege that God gave Tony a platform where he could pray with his players and their families or just sit down and talk with them. Sometimes the players' families needed someone to watch their kids when they went to counseling. We helped with that too.
Helping others can be one of the most fulfilling roles in life.
Tony and Lauren Dungy, authors of Uncommon Marriage, learning about lasting love and overcoming life's obstacles together. Discover more at CoachDungy.com.
If you owe back taxes and can't afford to pay, you need a fresh start. Take advantage of special IRS tax programs and be free from IRS collection efforts. That's right. If you take advantage of these IRS programs, you can stop levies and garnishments dead in their tracks. Get ready for the most important number you may ever hear. End your IRS nightmare and finally get a fresh start. This toll-free number should only be used if you can't afford to pay any money to the IRS. Call 800-890-1339 now to see if you qualify for these tax relief programs. Once you're accepted, the IRS must stop all collection activities against you. No more threatening phone calls, wage garnishments, or bank levies. Your fresh start could be a phone call away. Call Community Tax now at 800-890-1339 to find out if you qualify for these tax relief programs. Once you're in, the IRS is out in the cold. Call 800-890-1339 now. That's 800-890-1339. 800-890-1339. Again, 800-890-1339.
Mainly clear skies, a bit cold as well. Tonight's low 34 with frost in the colder inland spots to 54 at the coast. Partly sunny and a bit warmer with a nice afternoon. Monday's high 74 to 78. Comfortable Monday evening with mainly clear skies. Low 48 inland to 60 at the coast. That's your AccuWeather forecast. I'm Matt Roberts for Talk Radio 860 WGUL.
Welcome back to Outbreak News This Week, your source for all the news about worms and germs. Here's your host, microbiologist and editor of OutbreakNewsToday.com, Robert Herriman.
Well, welcome back to the program. And before we continue our discussion on Ebola, I want to go ahead and touch on a pretty big news story that I covered on OutbreakNewsToday.com on Wednesday, which is really, really big news, particularly in light of the meningitis outbreaks we saw last year at Princeton University in New Jersey and the University of California, Santa Barbara. And even more recently, we saw 2 cases in the San Diego area in the colleges and one in Georgetown in September. And that is the FDA has approved the first vaccine that offers protection against meningococcal disease caused by Neisseria meningitis serogroup B. All right, why is this a big deal? Because prior to this, the United States did not have an approved vaccine that covered serogroup B, which is a pretty common one. It's about 1/3 of the cases of meningococcal meningitis, meningococcal sepsis are due to serogroup B. Out of the 500 that we see annually, about 160 are by this strain of meningitis. So this has become something of an issue, particularly in the university and college environment, where this organism tends to affect more than others. And like we said, last year, Princeton saw an outbreak of 8 cases. UC Santa Barbara saw 4. And we saw, a couple deaths in the past couple months. And so this is massive news. And what FDA Director of Biologics Evaluation and Research, Dr. Karen Midthun, said is recent outbreaks of serogroup B meningococcal disease on a few college campuses have heightened concerns for this potentially deadly disease. The FDA's approval of Trumenba, hope I said that right, provides a safe and effective way to help prevent this disease in the United States. If you remember correctly, the end of last year into the early of this year, Princeton and UC Santa Barbara had to get special approval through the FDA, the CDC, to utilize a vaccine called Bexsero that's made by Novartis, which was only approved for use in Europe and in Australia. So this is huge news in this world of meningococcal disease, and this is going to save some lives, because if you weren't vaccinated, if you were vaccinated before you go to college, which most universities require, meningitis B was not covered, so you were always at risk for that. And hence, they could be treated with antibiotics, but antibiotic treatment with meningococcal meningitis is very timely. It's got to be very quick. You don't have a lot of leeway, because this is a very, very dangerous pathogen. So great news there. If we go back to outbreak news today, and let me see if I can look at one more thing that I got going on, is in, the headline right now is kind of to put the whole Ebola thing in perspective. My headline right now says West Nile virus deaths in the U.S. stand at 58. So we've seen the one Ebola fatality in the United States to date. But West Nile, there's already been about 1,700 cases in the United States with 58 fatalities. And right here in the state of Florida, we know we've had 13 cases and 1 fatality. So again, to keep Ebola in perspective, there's a lot of other things going on. And West Nile is not going to go away. West Nile, made its first appearance in New York City in 1999. Where does West Nile have its origins from? Uganda, Africa. So it's here to stay. It's now considered endemic in North America. It's seen as far north as Canada. And just something to really keep in mind, that other diseases like West Nile virus are out there and causing a lot of disease and suffering in the United States. Okay, well, let's get back to our topic of the day, which is Ebola. And I want to switch gears a little bit for my first guest and talk more about the Ebola virus and its transmissibility and related topics. And so joining me on the phone now to talk about this is Vincent Racaniello, PhD. Dr. Racaniello is a professor of microbiology and immunology at Columbia University in New York City. And Dr. Racaniello, a.k.a. Earth's virology professor, is also a renowned expert in virology with more than 3 decades of experience, particularly in the field of polioviruses. So, Dr. Racaniello, are you there, sir?
I am. Hello, Robert.
Hi, Vincent. It's nice to have you back. A great friend of the show. And the last segment I spent with Dr. Tara Smith, and we went over a lot of the stuff that's going on in Africa. Mm-hmm. But I wanted a virologist to go over some of these more particular topics concerning the virus. And a lot of this stuff is been misconstrued, and there's a lot of confusion with the media. So I'm looking at you to kind of try to iron some of this out.
I think it's a great idea, Robert, and as you know, I love explaining virology, so I'm happy to do it.
Fantastic. And by the way, Dr. Racaniello is in New York City, where the last Ebola patient currently resides. So I'm sure there's all kinds of stuff happening up there that you could talk about. First of all, Ebola virus it's a filovirus. I hope I said that right.
That's right.
Okay, and it's in the same family. It's the same family as Marburg. And I get to start out is, how hardy of a virus or how fragile of a virus is this?
Actually, it turns out that the filoviruses, at least Ebola viruses, and there are 5 different ones, as you know,
yes,
are pretty hardy. A number of papers have been published looking at this and subjecting the virus to different conditions and temperatures. And it turns out that if you put the virus on a piece of glass and you let it dry out and you put it in the dark, it will remain infectious for a couple of days. And now if you take it out in the sun, it gets inactivated quicker because the sun has a lot of UV light in it, and the virus is particularly susceptible to the UV irradiation. But in a darker environment, and there are plenty of those around, the virus can last for a while, and it's not so great at high temperatures. So 60 degrees Celsius, which is about 140 Fahrenheit, will knock out the virus in a half hour or so. And of course, as you go lower and lower, it takes longer and longer to knock it out. So and as far as viruses go, it's pretty hardy. The influenza viruses and the common cold viruses, they don't last that long on surfaces. So it's something to think about.
Okay, well, that's interesting. So that brings me to my next point then. You're in New York City. Dr. Spencer, it's been reported that he traveled public transportation. He went bowling. So I've heard a lot of hyperbole on the radio and stuff and on cable news. What is the real risk of me picking up Ebola at a bowling alley?
I think it's really small. I think you're more likely to walk out the door and get hit by a car or run into a fight in the bowling alley than to pick up Ebola infection. So Dr. Spencer, when he was at this bowling alley, apparently did not have any symptoms. And, the sort of rule of thumb that we're used to hearing is that at that point in an Ebola infection, you're not contagious. There's no doubt that he had Ebola virus in him because the next morning he developed a high fever. But we don't know of any information that would suggest that someone's contagious. So we don't know if he's shedding small amounts of virus or not at all. These are really questions that need to be answered. All we know is that he doesn't, at that point, one doesn't transmit infection. So let's say he was sweating and, he's got his fingers in the bowling ball, right? And maybe if his sweat did contain virus, you can imagine that it would go in the bowling ball. And as I've just told you, it would probably last in that dark hole in the bowling ball for a couple of days. We don't know if it's enough to transmit to another person. But when people ask me about this, I've been asked a lot about it, I tell them, look, if you put your fingers somewhere in a bowling ball on a subway pole, just don't touch your face until you wash your hands. It's common hand hygiene because that's how you would infect yourself if there were virus on the bowling ball or on the subway pole or on a doorknob.
Whether it be flu or cold or anything.
Yeah, it could be any virus. All of us touch our face all the time, right? Our eyes, our nose, our mouth, and then the virus would get in and infect. So, I go on the subway all the time. I don't touch my face until I get back in the lab and wash my hands. And that's really the thing that everybody can do to protect themselves against all sorts of viruses. So the bottom line is I think it's really unlikely, incredibly unlikely, that anyone would get Ebola virus from that bowling ball that Dr. Spencer used.
Okay. Now, it kind of segues into the next question. Based on the best available research, if I was to go by Dr. Spencer right now and he was to cough on me, how many virus particles, what's the infectious dose that's required for me to come down with Ebola?
Okay. So for people, we really don't know because, as you know, you can't do experiments on people. And the only experience we have is we pick people up like Dr. Spencer after they're infected, and we really don't know how much virus they receive. Now, Dr. Spencer likely got infected taking care of a patient in West Africa, and that was a sick patient, so it was probably producing quite a bit of virus, and he probably got some fluid on him in some way and contaminated himself. So I can't answer the question, and I don't know anyone who can for people. We know in animals, in laboratory animals, you can infect mice with as little as one virus particle, and non-human primates, 10 virus particles are enough to infect them. But we just don't know if that applies to people. You know, these are experiments done under laboratory conditions where everything is well controlled as opposed to in a hospital room. So I would guess that you need a good dose, whether it's 10, 100, or 1,000 virus particles. We just don't know, and I'm not sure that we'll ever be able to figure that out.
But would it be fair for me to say, though, that if I was to have seen Dr. Spencer one day after he started showing symptoms, as opposed to these nurses in Texas that were treating Mr. Duncan on his deathbed, there's a massive difference of viral load.
Absolutely.
Yeah.
So people have studied that in infected humans, and as soon as symptoms begin, you get an increase, and over the next few days, as the symptoms intensify, you get more and more virus to the point where you have a lot of virus, quite a bit of virus in the blood. So the later on in the disease you contact someone, the more likely you are to get infected.
Okay, sticking with the whole Dr. Spencer thing, some of the media was talking about that, he could have been infectious while he was on the public transportation. And I don't know if there's an answer to this either, and hopefully you'll enlighten me in the audience. There's got to be some kind of, is there a fine line? Is there a actual point in the infection when that person becomes a danger to others?
All right, so this is the so-called 21-day quarantine period, right, during which we say if you don't show symptoms, then that's the definition of the incubation period, right. You're not contagious. Now, Dr. Spencer was infected at some point in Africa, and as he came over to the U.S., the virus was probably multiplying in him. And when he was bowling, he certainly had virus in him. But then the next day he had a fever and he had more virus, and at that point we consider them to be communicable. It's not like all of a sudden from 1 minute to another as the fever goes up, the virus is suddenly spewing out of the patient. It's probably there, but at very low levels and not enough to infect anyone. And how do we know that is really the important clue, because I think all the people that I interact with always want to know, how do you know that? How do you know that someone is not communicable until symptoms appear? Well, it's based on our experience, mainly in Africa, at looking at infected people. We know that the biggest risk factor for people who have contracted Ebola is butchering bushmeat, being in contact with a sick person, for example, and families preparing the bodies for burial, healthcare workers who take care of these people. Those are the main risk factors that account for most of the cases. There's no risk factor of being in a room or shaking hands with someone who 3 weeks later got Ebola. So that's why we say they're not contagious until symptoms appear, because we have no history of that really ever happening. Now, biology is flexible, and it could be that at some point in the future, if we study a number of infections here in the U.S., we might say maybe 24 hours before the fever there is some contagion. But that absolutely is not the case at the moment, and so that's why everyone says you're not transmissible during the incubation period.
Okay, Vincent, how did they arrive at the 21-day incubation period?
Okay, so again, it's from studying the outbreaks in Africa, and there have been, up until this one, there have been 23, I think. What they've been able to do in all of those outbreaks is trace the chain of transmission back to the first case. So in a lot of cases, there were people who butchered bushmeat, and the first person who got infected got the infection from there. And then they can trace it through all the other people who got it from that individual. So when they do that, they can tell how long the incubation period was, because someone will say, oh, yeah, I went to visit so-and-so who was sick on this day, and they can calculate for each of these contacts the rough incubation period. Of course, it's not entirely precise, and that's why we have a range of 2 to 21 days. Now, in the current outbreak, a paper was published not too long ago looking at the incubation periods in the current outbreak to see if they fit that 2 to 21 day pattern. And the analysis of all the information available said that, yes, that's a good range. The current outbreak fits the same numbers, 2 to 21 days, with about a 2 to 10% chance that it might be slightly longer. Okay? So there's some possibility that in some of the individuals, just due to the nature of observation and looking at symptoms and so forth, that it could be slightly longer than 21 days. But the vast majority of people are still between 2 and 21 days. So that's how they get it, by looking at previous outbreaks and the current one as well.
Very good. I am talking to Dr. Vincent Racaniello with Columbia University. Vincent, I guess one of the more confusing and misleading topics we've been hearing about on news and radio is whether or not Ebola is airborne. And I've even heard it around the water cooler, so to speak, at work, that people are saying, well, I heard it mutated and became airborne. So, and it's funny because a colleague of mine who blogs about infectious diseases, his name is Mike Costin.
I know Mike.
Sure, yeah. Avian flu diary.
Yeah.
I'm paraphrasing what he wrote one time, but he said, basically common sense dictates if this thing was airborne, you'd see a lot more graves.
Absolutely. We'd be in big trouble if it were airborne, absolutely, like influenza, for example. So, now, unfortunately, much of the press has been propagating this idea that it's already airborne. And I think part of the problem is a misunderstanding, because the way virologists and epidemiologists define airborne is very different from what the person on the street thinks about. So we say a virus is transmitted by the airborne route when you can be in a room 20, 50 feet away from other people, and they'll have influenza or measles or a common cold, and you'll get it from them because as they're talking or sneezing or coughing, they're exhaling very fine droplets, really small, that have viruses in them, and those can float in the air for long distances, and you'll inhale them and get infected. That's what we mean by airborne transmission. And Ebola virus is not transmitted that way. We know because, as I said earlier, the risk factors for infection in the previous outbreaks involve close contact with an infected person, not just being in the same room. Now, a lot of people have said, well, can't you get it if someone with Ebola vomits on you? And the answer is yes, you could. And they say, wow, that's airborne. Isn't the vomit going through the air? Yes, technically the vomit is going through the air, but that's not considered an airborne route of spread. That's actually we call that a contact mechanism, and to many people that doesn't make any sense, but that's just the way it's defined.
But that's still considered direct contact. It's
considered direct contact because you need to be a few feet away, obviously, for even someone with projectile vomiting to hit you, right? And that you can also imagine that if you're standing, say, within a couple of feet of someone and they sneeze right at you, very big droplets are going to come out when you sneeze, and they would typically fall to the ground within a few feet. But if you're within that distance, they're going to get on you and you can get infected. So technically, by the layperson's definition, the drops are traveling through the air, but again, that's considered a form of contact transmission. So Ebola virus is not transmitted by the airborne route. There's just no way around it. That's the way it is.
Okay. Let me switch gears to mutations. To the best of your knowledge, has this particular outbreak strain mutated at all?
It has mutated, just like every other virus mutates as it moves through human and animal populations. And in fact, there was a very nice study published in Science a couple of weeks ago where they acquired a number of the virus isolates from people in the West African outbreak, and they determined the sequence of the genomic material. And they could see that the virus is indeed changing. But it still looks like an Ebola virus, and it doesn't look like any of the mutations are endowing the virus with any particular properties. So when we say mutating, all we mean is that the genetic information is changing. It doesn't mean that the properties of the virus, the virulence, the transmission, the length of time it lasts on a surface, is not necessarily changing when the virus mutates.
Okay, is there a history in the history of virology, human virology, is there a history of a virus that mutated to the point where the mode of transmission changed?
I am not aware of any human virus mutating to the point where transmission mode changes from contact to airborne, for example. And we've been studying viruses for just over 100 years. We've looked at many, many different infections, all kinds of transmission routes, and it's not just me, but many, many of my colleagues will agree, none of them have ever changed their mode of transmission. So it's probably a really rare event. Doesn't mean it can't happen. It might have happened before we started studying viruses, but because it's been so rare in our history of studying viruses, that's why we say it's really, really unlikely that Ebola is going to be any different.
All right, Vincent, I'm getting a little short on time.
Sure.
I got about 2 minutes left, but I wanted you to talk about this real quick. I recently received an email, and somebody was very irate with me, and they said how come you don't talk about the Canadian study that showed Ebola spread from pigs to monkeys that were not even in the same room together? Is this study even applicable to this conversation?
Okay, the study you're referring to, they put pigs and monkeys in a BSL-4, a high containment lab. They were in the same room. The pigs were on the floor. The monkeys were in cages stacked on one another. And they infected the pigs with Ebola virus. The pigs got infected, and the monkeys got infected. But we can't say that that's airborne transmission because the pigs, they make a mess on the floor, and every night someone had to come in and clean it up, and it's possible that they stirred up the virus that was on the floor and made droplets sprinkle onto the monkeys and infect them. So it's in the same room. It could have been just droplet infection. And when those monkeys got infected, they didn't transmit it to each other. So even though it might have gone from pigs to monkey by droplets, among the monkeys, it's never been shown to be transmitted through the air.
Well, very succinct, Vincent. Thank you very much. All right. Well, I'm out of time. I've been talking to Dr. Vincent Racaniello. He's a virologist, a professor at Columbia University. Thank you, Vincent, for your time and expertise, sir.
Robert, always a pleasure, and I'm happy to come back anytime.
Fantastic. Thanks a lot.
You're welcome.
All right. Well, I'm going to go ahead and wrap up the show now. I want to encourage you to visit the website, outbreaknewstoday.com, for all the latest and greatest news on infectious diseases. We also have a sister site. It's called theglobaldispatch.com. I encourage you to check that out. That's where we cover more mainstream news, politics, and a lot of pop culture. If you're into that, movies and television and all that, it's a great place to go. I want you to go ahead and join me next week. I'm looking at Hillsborough County's had an increase of a parasitic disease, and I'm looking at talking about cryptosporidium. So I'll see you next week. Thank you very much.
Thank you for listening to Outbreak News This Week with Robert Herriman. If you missed any part of today's program, you can listen to the podcast anytime on our website, talkradio860.com. You can also find out more at OutbreakNewsToday.com. Make sure to join us here next week at 5 for Outbreak News This Week with Robert Herriman on Talk Radio 860, WGUL. Talk Radio 860, WGUL.